Hello, and welcome to today's town hall. My name is Emily Kosick. I'm a knowledge manager at the Canadian Institute for Public Safety Research and Treatment. Today's town hall topic is public safety personnel experiences of the opioid crisis. Before we get started, I do have a few housekeeping items to go through. First, all attendees are in listen-only mode. This is so that we don't get feedback during the presentation. If you do want to ask a question, please just submit it through the question box, and we will get to your questions at the end of the session. Today's session is being recorded, so if you missed something or you want to watch it again, a copy will be sent out to you within the next 48 hours. Just so you know, some organizations do block GoToWebinar software. So if you're having an issue hearing us, you may have to join by phone. Okay. All right, so let me get to introducing today's presenters. So our first presenter is Dr. Nicholas Carlton. He's a scientific director at CIPSR, and he's a professor of psychology at the University of Regina. Our second presenter will be Chief Pierre Poirier, the Chief for the Ottawa Paramedic Services. Our panelists today are going to be joining us by phone, Superintendent Chan Dara. He's a Criminal Operations Officer for the RCMP in the Yukon. We also have Constable Dave Steverding from the Vancouver Police Department. Sorry about that, David, I messed up your last name, I'm sure. Lastly, we have Kim Van Herk. She's an RN and a mental health team lead at Ottawa Inner City Hospital. So I'd like to welcome everybody to the presentation today. Nick, I am just going to turn over the sharing ability to you so you can go ahead with your presentation.
Terrific, thank you. All right, and does that look correct, Emily, just to make sure?
I'm just seeing a white screen at the moment. Aha, there we go.
Terrific. All right, thank you. Thank you very much. I'm very happy to be here this morning for our presentation and to try to provide some backdrop and support to our panelists. I'm a professor of psychology. I'm a registered clinical psychologist in Saskatchewan. I have no relationships with commercial interests, and my research is very much supported by several different agencies, for which I'm very grateful. This morning, I'm going to be providing some general information and backdrop to inform our conversation on the opioid crisis and to provide some foundational information for those who might be interested in the history. Opioids have been used worldwide, certainly for probably thousands, if not more than that, years. In the 1930s, though, we really see a change that starts to occur where opioid use becomes banned because of increasing evidence of high mortality rates. And then in the 1950s, we've got pharmaceutical companies who are beginning to develop synthetic opioids in order to help with cancer patient pain management. In the 1980s, we see a push to begin using prescription opioids for any kinds of chronic pain. And there's actually an increased marketing effort on the part of several pharmaceutical companies towards healthcare providers to increase the sales and the use of prescription-based opioids. By the 2000s, we start to see opioid abuse becoming an increasingly pervasive and problematic issue, particularly in North America. And a lot of that is being driven at that point in time by prescription use and the increased use of opioids for pain management. By 2007, Purdue Pharma pled guilty to having misled regulators, doctors, and patients about the risk of addiction and dependence formation associated with OxyContin. And by 2016, we see the government of Canada beginning to provide extensive tracking for the impact of opioid use on the general population. So we've gone from thousands of years to just the last 100 years or so, making major changes with respect to how our population is interacting with opioids. Prescription opioids certainly contribute to the crisis. That's what the available evidence so far suggests. But in Canada, it's actually the illegal drug supply that is causing a significant portion of our problem with the opioid crisis. And a lot of the illegal drugs that are being made available, especially the the street drugs, are actually tainted with particularly powerful opioids, things like fentanyl, which is difficult to identify simply by sight, smell, or taste. So an almost invisible amount can be absorbed quite quickly through the skin, and that can be quite lethal. So let's talk about some of the crisis by numbers. In 2006, from January 2016 to March 2020, approximately 16,364 people have died, more than 20,000 have been hospitalized, and there have been over 4,500 suspected overdose responses that paramedics have made. And that's just, that last figure is just from January 2020 to March 2020. So we're seeing a really dramatic increase in the amount of influence and the amount of case numbers associated with opioids. Most of the cases are in the 20 to 39 age group, and the overwhelming majority of those are male. So we're seeing a significant increase, particularly in this year, and we're seeing a significant increase over the last 4 years with respect to our challenges with opioids. The federal government has taken several actions to try and combat and challenge the crisis, making naloxone kits freely available, raising awareness in order to hopefully help to manage some of the stigma challenges that go along with opioid addiction, approving supervised consumption sites as part of a harm reduction strategy, increasing access to treatment so that we can help people who are addicted to or having difficulties with opioid use to heal and to recover, and also to provide protections against minor drug possession charges so that more people are likely to call for help due to an overdose rather than fear the potentially criminal implications that go along with calling for that help, given that that fear can then lead to increased rates of death. So what about the impact of COVID-19 on this crisis? Well, Altenberg was quoted in April 14th, 2020, "Since COVID began, we've seen the highest number of overdoses since 2017. So what happens when the opioid epidemic meets a global pandemic?" Well, this is a really important question, and it's a challenging one. Been several changes that have been made already. Pharmacists and practitioners have been provided temporary capacities to support prescriptions in order to make sure that we've got access to the medications that are necessary to combat the crisis, both with harm reduction and with interventions. There have been exacerbated stressors as a function of COVID-19. So there's a blanket increase in stress that everyone is experiencing, and they're experiencing it in different ways. We're seeing that increase in stress being associated with an increase in substance use. But that increase in substance use is not universal. There's significant sociocultural disparities. There's challenges with isolation, fear, anxiety, supplies, safety. And all of that can differentially exacerbate the use of all substances, including opioids. It's also been exacerbation seen for people who are in particular need of healthcare support because of their substance use challenges. And in addition to all of this, there are PPE requirements that have exacerbated challenges specifically for our public safety personnel in their attempts to deliver life-saving and harm reduction services. So we're seeing compounding challenges on all fronts as a function of COVID-19 meeting the opioid epidemic. Let's talk a few more numbers. In Ontario, the data so far suggests there was a 38% increase in opioid-related deaths within the first 15 weeks of the pandemic this year. There's also evidence that deaths themselves have increased significantly among males, from 69.7% to 78% of total deaths. And there's evidence that fentanyl is a more common contributor, specifically for 87% of the deaths, which is an increase of about 8% from pre-pandemic death rates. In British Columbia, paramedics have attended overdoses at rates more than double that of since before the pandemic, going from 17 out of every 100,000 people to 35 out of every 100,000 people. And the bulk of that increase has been among male users. We've seen a 130% increase in deaths, from 1.5 to 3.5 deaths per 100,000. And we've seen a significant increased uptake of the take-home naloxone kits, which suggests that there's increased use, which is, of course, likely to be associated with the increased death rates. So let's talk just very briefly about how our PSP may be experiencing the increased confound variables that go along with COVID-19 meeting the opioid epidemic. Broadly speaking, our public safety personnel may be required to repeatedly use extraordinary efforts to save the lives of people who are suffering from addiction. And in doing so, they may not always be greeted they may not always be thanked for their efforts. And in addition to not being thanked for their efforts, they may actually be repeatedly exposed to the same kind of potentially psychologically traumatic event. Broadly speaking, potentially psychologically traumatic events include any risk of death or severe harm. Well, an overdose is certainly associated with death and risk of severe harm. However, in this case, there's also moral injuries that may be particularly impactful for our public safety personnel as part of the COVID-19 and the opioid epidemic. And those may be increasing mental health challenges for all our PSP. For those who aren't familiar, a moral injury is generally defined as experiencing a significant violation of one or more deeply held moral beliefs or ethical standards or spiritual beliefs, or experiencing a significant betrayal or witnessing trusted individuals committing atrocities. Well, there's a lot of different morality that is in conflict right now, and or at least could be perceived as being in conflict right now as we navigate a COVID-19 pandemic and as we navigate an opioid crisis, where PSP are watching people engaged in repeated use as a function of addiction, but our PSP are pretty well informed about the kinds of additional socioeconomic variables that are associated with those kinds of addictions and those kinds of deaths. So that creates an opportunity for a significant increase in the number of moral challenges as people who are particularly vulnerable repeatedly make use of escape tactics like opioid use in order to navigate the challenges they experience in their daily lives. So, with all of this as a significant backdrop, I want to thank you for taking a few minutes with me this morning to get some of the parameters around the challenges that we're discussing. I'm now very happy to turn it over to our panel, to our next presenter, and then to our panelists. Thank you, Emily.
Thank you, Nick. Pierre, I've got your slide up there for you, so you should be good to go.
Thanks, Emily, and thank you, Dr. Carlton, for setting the stage today. What I only have 2 slides, but I just want to spend a couple of minutes to kind of highlight the evolution of paramedic mental health, the understanding of paramedic mental health, and also its relationship to the opioid health crisis, and trying to line these 2 up, and then talk a little bit about the importance of language and terminology when we discuss this topic. So. Just first off, on this slide, the dark purple and the light purple are both standards that have been developed in concert with the Canadian Standards Association. The lighter purple is standards that have been specific to paramedics. And if I start on the left side, there was a standard developed around 2011 with respect to psychological health and safety in the workplace. In 2014, the paramedic community realized, amongst other things, that we wanted to really develop a standards framework to look at a number of issues, and mental health being one of them. So the light blue there is reflective of the Ontario government and their Ministry of Labour, and they had an occupational health, safety, and prevention innovation program, which supported the development of a specific paramedic health and safety standards. So in 2018, the Psychological Health and Safety and Paramedic Service Organization came to be. And it's a standard that's been widely circulated and is well recognized because it really does start to highlight the importance of mental health as, and I don't want to say a job hazard, but it is something that is significant in the paramedics world of what they do in terms of work. Historically, paramedics and services have been concerned about the physical, musculoskeletal injuries and the impact on the service, but more recently has been an appreciation of how important mental health is in the work that paramedics do. So if I line this up a little bit now with the health crisis, if I go back a number of years, Minister of Health Jane Philpott was deeply concerned about the evolving opioid crisis, and a physician herself, she was very sensitive to this issue, and this probably goes back a number of years. We're talking 5 to 10 years. she approached the paramedic community and said, I think there's more that you can do with respect to this issue. And so through the Substance Use and Addictions Program, which was sponsored by the Public Health Agency of Canada, the paramedic community was able to acquire a grant, and that's the, I don't even know what color to call it, the flesh or the pink colored box there, to develop an innovative response to Canada's opioid crisis across the prevention, harm reduction, and treatment continuum. So the interesting piece about the support that the paramedic community received from government here was that it was twofold. One was the development of a standard, which you see below, which will be released actually hopefully in January or February. And it's with respect to the paramedic response to the opioid crisis. And an important piece of this program that's been supported by the federal government is a second piece, where there's a commitment to knowledge translation. And that really is about not just having something or a document that sits on the shelf, but actually promoting the document and getting it into the broader community. So the knowledge translation isn't just for the paramedic community, it's for the broader community as a whole, that we actually have some information going out to the community about how we treat individuals with addictions and use issues, as opposed to just simply having the standard out here that may be available for use. So that's kind of the context of linking the paramedic mental health issues with respect to the development of a response by the paramedic community to the opioid health crisis. The second piece is, just before you go to the next slide, Emily, on the weekend in the Globe and Mail on December 5th, you can go, sorry, Emily, you can go to the next slide, no issues. There was an article in the Globe and Mail, and it struck me about, in some ways, how far we've come, but how far we have to go. In the article, a mother was speaking out that she had recently lost her son to an overdose. And it was interesting that how far we've come, but how far we have to go in terms of the language that we use and how we talk about this. In her comments in the article, she specifically says, she decided right away that she was not going to make a secret of what happened to her son. He was sick and there was no shame in it. And I think that language is very important as we move forward when we talk about issues related to addiction and issues related to drug use or substance use. And I even know, and I speak personally for myself, that I have difficulty adjusting my language to really something that is neutral in terms of its presentation. Years ago, we talked about alcoholism as something that was a character flaw or something that was negative. The evolution there has been that we recognize it as a disease process, and more we have to adjust our language to recognize that. And that's the same with substance use and addictions, is that we have to adjust our language so that we don't promote or maintain the stigmas that go along with these events. And just to put it in context, that when you look at the federal government program, it was about substance use and addictions. It was neutral language specific to what is occurring, with a recognition that for the most part, there may be a mental health issue, but there may be the addiction as a disease process, not as something there is a value judgment placed upon those individuals. And that's really is an important piece. And that's why stigma is such an important piece of the language here. And it's stressed for the paramedics in terms of how they deal with individuals, but also in terms of our broader community. And just to give you a couple of examples of contextualizing the terminology. When we say opioid use disorder, is there a better way of saying that? Ongoing dependency or addiction. So it's something that's neutral in terms of language. And then the second piece is, here's another one that may be more obtuse or abstract: overdose. It's the consumption of opioids that interferes with normal functioning or activity. These are kind of the movement in terms of recognizing that opioid use, that we have to take a look at it from a perspective of, and I want to say neutrality, and more of a caring perspective with respect to this. The last point is that we've often seen that, and I'll use the example here in Ottawa, is that the issue with respect to overdose, or those individuals who have overdosed, is that when that event was happening in the downtown core, and it's been happening for a number of years, it was never really highlighted within our community or within the broader media. More recently, in a rural suburb of the city, a couple of years ago, it was a 14-year-old girl who was in an affluent community who overdosed and sadly passed away. And at that point, it became an issue within our community, which is kind of an interesting commentary on society and how we view these things, but also how important it is that we have that evolution to recognize not just the language, but also in terms of our own biases and prejudices of how we look at this issue. And that's probably what my point here is, to stress how the importance of language and terminology and how we contextualize use and addiction. So thank you, Emily. I'll turn it back to you.
Perfect. Thank you so much, Pierre. So I'm going to go ahead now, and I'm going to have our panelists answer a couple of questions and share their experience with us. So first of all, I want to ask each of you to share your experience working with the opioid crisis and during the opioid crisis. So I'm going to start with Superintendent Dara. Whenever you're ready, go ahead.
Good morning, everyone from the Yukon here, and great presentation so far. I'm just going to provide a little bit of information from our perspective as the police of jurisdiction in the Yukon, so in the Northern Territories. Obviously, our realities here in the Yukon are somewhat different than what we're seeing in Nunavut and Northwest Territories, but of late, we've had a problem, and we've been having a problem with fentanyl and overdoses for a few years now, and it comes in waves. And I could tell you that during this pandemic, we had our wave of opioid-related deaths in the territory for which we responded. So to give you a context on how law enforcement is involved, we oftentimes get 911 calls to respond to overdoses. Now, you know, there's a number of reasons why. Maybe the call is funneled through the 911 system to the police instead of EMS first, or sometimes the police happen to be closer and able to respond quicker to these calls. But oftentimes, EMS is either already on scene or they're not far behind us. And the calls that we do attend and arrive first on scene, you know, I'd like to say that oftentimes we're able to administer naloxone and everything is well. And I could tell you that on average in the last few years, we administer in the whole territory naloxone approximately 7 times each year. But during this pandemic, there was an uptick in overdose calls that we've had to administer the naloxone. I would say since from March to now, probably over 15 times approximately. But unfortunately, a lot of the calls that we do go are fatal overdoses. Yeah, and in the majority of those cases, the victim passed away alone. Another trend that we're seeing up here, and I guess it's a good thing, but it's also something that's worth looking into more deeply, is that the Yukon government is very progressive here. They have naloxone kits available for anybody, everybody, freely available. There's a number of NGOs that support addiction, people to combat addiction. But what we're seeing is that users are using the naloxone kit to sort of as an emergency, which is good, I guess. But they're using the opioids, and when they feel like they're going to pass out and fall unconscious, they administer themselves the naloxone. So we don't know if that's working all the time, but we did on a number of occasions find that when we do get called to an overdose, we did find that person who overdosed had a naloxone kit available, but just wasn't able to, for whatever reason, administer it. And another thing that we're promoting here in the Yukon, our social services here and our chief medical officer, is promoting that, you know, if you're going to use in these difficult times, please ensure that there is somebody with you to do so. So we feel that that is somewhat mitigating the fatalities in our territory, but they do still appear in batches. And now for the second question, how does it impact first responders from continuously responding to these calls?
Superintendent Dar, I'm just going to pause you there for 1 second. We will move to that question next. So if you don't mind holding your answer, I will get back to you. But I am going to go ahead and turn the first question over to David for his answer on his experiences of the crisis.
Okay. Good morning, everyone. David Steverding. If there are any Vancouver police officers, like our executive members that are watching this, I'll put a disclaimer out there. I do not speak on behalf of the department. They'll probably breathe a sigh of relief on that one. My experience as far as the opioid crisis, just some background, I'm a 16-year member of the Vancouver Police Department. Worked primarily in the area in Vancouver known as the Downtown East Side. Specifically for myself, I'm part of what's called the Beat Enforcement Team. It's approximately 4 square blocks dealing with probably the most severe addicted people and people suffering from mental health issues. This is an area where people go to disappear, or where people simply are facilitated in their drug use. And I'm not saying that in a cruel way or condescending way, but the environment down there, basically, it is the Downtown East Side has existed as it has for probably the last 30 to 40 years. Gone through a variety of different types of drugs of choice or circumstance for people. So first it would have been heroin, cocaine then making an appearance, then crystal meth, then crack cocaine being the predominant drug of choice. I realize there's a difference between stimulants and depressants. But crack cocaine was the predominant drug when I started working down there. And then in the late 2000s, heroin started making a real strong appearance or a bounce back. And then about 2014 was when we first started observing or seeing a spike in overdose deaths. And then eventually that was associated to the basically fentanyl making its appearance on the scene in Vancouver, specifically the Downtown East Side. So in terms of the population base, we're about 16,000 people, maybe 18,000 people in this area. Probably well over a third of those people suffering from some type of addiction. Going back to the original group, probably a third of those people suffering from mental health issues. I've heard estimates as many as 2,000 people in the Downtown East Side that are either undiagnosed or unsupported in their mental health issues. Quite a tragic area. As far as the environment goes now, I left in 2014, returned about a year later, and then I did some other projects. But what's changed since I started working down there is, despite the fact that not only do we have the supervised injection site in the 100 block of East Hastings, we've had 3 other injection facilities open up. Majority of the single room occupancy hotels have, if you want to call it a shooting gallery, a place for people to fix inside the building. We have had an explosion of giving out needles. We've had basically all the drug paraphernalia people need to take to consume their drugs. We've had an explosion of naloxone kits. It's funny because the doctor was talking about that the federal government facilitated the supply of naloxone kits. We were in a little park in the Downtown East Side. We came across about 30 of the kits just sitting there abandoned. So the naloxone kits are just readily available. I do carry naloxone kits. As far as the environment goes, it's interesting because from different perspectives of first responders, I think police were the only first responders that would be potentially investigated by the investigative branch that investigates police misconduct. So when we started administering naloxone, there was the issue that we would potentially be investigated for misconduct for administering naloxone. I think that was something that we had to face. Also the fact the open drug use, just the fact now we have people that are openly consuming their drugs out on the street, despite the fact that we have multiple facilities for them to consume the drugs. And I know there was talk about that there's been an increase in supply for treatment. Down where I am, with all due respect to everybody, that is a freaking joke. I'm sorry, but we have made no increase in supply for people that need treatment down there. And for me, treatment for people that are in the downtown east side, the first point is to get them the hell out of that particular neighborhood, and to get them in a positive environment. We are doing absolutely nothing for the people down there. And I will stand by that statement. Basically, I've been to 3 overdose deaths in the last 2 blocks. Since getting my naloxone kit, I've administered naloxone to three times to people. I've also had to do CPR on people, simply because the paramedics are so overburdened with what they have to do, that we cannot get paramedics on scene. The gentleman that I had to do CPR on, they didn't arrive, I believe, until 11 minutes after the phone call was made. Even the firefighters didn't come for probably another 8 minutes. So the other side of it is that the paramedics, when they go to overdose calls, whether the person is deceased or any type of overdose death, for us, we get called automatically. The paramedics do not feel safe going into a lot of these environments, so we are by default going with the paramedics in a lot of cases because they have so few resources. We wind up on scene before they even get there. Sorry, it almost sounds like some sort of how would you call it? Some sort of session for me to not to gripe, but where I'm releasing a lot of frustration this morning about this. Yeah, I'm not sure what else I can say just in terms of what's going on. But I will say down where I am, anything that's being done is a absolute abysmal failure. The one other part too about not charging people for small amounts of drugs, we have essentially operated, the city of Vancouver, BPD in particular, we have operated in essentially a no charge for small possession environment for probably the last 10 years. So, oh yeah, that's nothing new. Retired Inspector Ken Frail actually introduced that in the downtown east side as a policy years ago and made it abundantly clear that our interests are not in charging people for small amounts for simple possession charges when we are attending overdose calls. And we are only there to provide safety for the paramedics who do not feel safe going into the environments that they're going into. So that's my experience so far.
Thank you for sharing that, David. It's an important experience, and that's what we're here. We want to hear the experience of people on the front line. I am going to turn now to Kim. I want to go ahead and give you an opportunity to share. You're actually a nurse that's working, I believe, at a safe consumption site. Is that correct?
So I am a mental health nurse. My name's Kim. Thanks for having me on the program. And I'm a mental health nurse. So we actually, it was labeled as a hospital, but the organization I work for is Ottawa Inner City Health. So we have medical units in the homeless shelters in Ottawa. So I work in the downtown where Pierre was talking about. And I've done this work for 13 years now. And I think when I reflect on the opiate crisis, when I started working as a nurse down here, I didn't even know how to respond to an overdose. We didn't have overdoses. We definitely have had deaths when I look back now over my time where they probably were overdoses, people that we found in bed in the morning, but minimal, 3 or 4 people over those 13 years. And we have a lot of deaths because our clients are quite ill. I care for the most medically and mentally ill people, I would say, in the city. Yeah, so in 2017, the opiate crisis hit Ottawa. And as nurses, we were literally, trained in Narcan at that time. It was not something we were doing beforehand. And we had nurses that were literally giving Narcan to people through fences and saving people's lives going through fences and jabbing people that were on the other side dead. And it was harrowing. It is still harrowing work. In that, when David's talking about crowd control for paramedics, as nurses, there were times where we were in the middle of an overdose trying to save somebody's life, and people were not always happy that we were giving Narcan. It is the tricky part of when people wake up from an overdose, they're not usually at their best. They're often can be quite aggressive. So it is harrowing work as a frontline person, but also there's the people around that are still high and using, or maybe don't want you to give them Narcan, because the effect of Narcan is you're literally taking the opiates off the receptors. So people go into withdrawal right away. And so a fellow opiate user will be like, don't do that to them. That's horrible. They're going to be in withdrawal. Like, how would you do that? And you're like, no, like, I need to save this person's life. Like, let me do this, please. But so that's a lot to manage. And so we came up with this system in the one shelter in town where we like had a code, because we were responding to overdoses all over this one block in downtown Ottawa, that we would get a call and start to have like a team that would go. And so then you had people helping with crowd control, as well as helping to save that person and do the Narcan, because this isn't a case of giving one jab of Narcan and somebody wakes up. This is 8 to 10 to 12 Narcans consistently that we're to give people to wake up. As the fentanyl changes, if there's different types of fentanyl, you'll have times where a different drug comes into town, and all of a sudden you are seeing way more overdoses again. You're having to do CPR, etc. So so the overdose crisis hit in 2017, and we were really used to doing harm reduction. When Dr. Nicholas talked about like alcohol, we had a managed alcohol program already. Like alcohol we had, and we still had our Listerine drinkers that we were bringing in. And then the opioid crisis hit. And so for us as healthcare professionals, it was really about, okay, so how do we respond to this? So it was, at the beginning, it was really around getting everybody trained on Narcan. And then we also got a safe injection site. So, and part of us doing our safe injection site was really about getting people, and the whole piece of recovery and trying to help engage our clients in getting care was about getting peers involved. So we had, which was something we did not have before. So we had people with lived experience of addiction get hired by our organization. And so this group has been really helpful to us. They're amazing at saving people's lives. They're fantastic at doing overdoses, but also really good at engaging clients. So they help us get clients to appointments, they help us get clients their ID, they help us sometimes get clients engaged in treatment, or for myself as a mental health professional, there's a lot of stigma around, there's still a lot of stigma around having a mental health issue. And often the reasons that people are turning to drugs is to treat their mental health issues or their trauma. And so if the peers, if they trust the peers can often like help people come see myself or our psychiatrist or a physician, so that people are getting other things attended to. We also have primary care, so we're seeing people and treating people for abscesses, HIV, Hep C, like the things that are the other pieces that are associated with drug use. And I think I do, so I definitely would say that it's been a very big struggle for us. We are now doing things like we have a managed opiate program, we have safe supply, and it's been, as healthcare professionals, we've been taking on huge risks trying to treat this population and really address the severe addiction and mental health issues that we're seeing. And so I just lost my train of thought. The working in this double pandemic has not been good for my my mom brain, but I'm slowly getting Alzheimer's as we talk. But all that to say, we have done quite well, knock on all the wood, during COVID, as far as losing clients to COVID, and we were very scared about that. So we have not lost clients to COVID, but we have definitely lost clients to overdoses during this time. Yeah, death has, and people, and I think the really discouraging thing that we're seeing right now is that people who were long time, drinkers, for instance, are now turning to opiates. And I think as somebody, who has worked out here a long time and has known some of these clients for the whole time I've been out here, to now see them turn to opiates is really discouraging, because it just, alcohol kills people, but it's a slower process than an overdose. So it is definitely, yeah, it's a difficult crisis to witness, for sure.
Okay, thank you for sharing that with us. I am going to move to our second discussion question, which, based on your experiences, I'm hoping you'll be able to provide some insight. So, as someone who's had to deal firsthand with this crisis, what do you think that governments, policymakers, mental health professionals can do to keep the people on the front line safe from the potential trauma of attending these multiple opioid-involved overdoses or situations, or what can be done to help deal with the frustration of the revolving door of people using opioids? And David, I'm going to start with you. It's a long question.
Oh God, it's like being back in elementary school, hoping that you're not the first one to go when they ask the question. Yeah. I've unfortunately, as the result of my my career choice, my sense of humor has become extremely morbid. And the first thing, like, what can they do to help? Or in terms of the question that was asked, my first response was going to be a bottle of rum, and I know that's not productive. Yeah, sorry. You know what? I'm really stumped by that question. Like the way it was asked on the first part, unfortunately for first responders, I think our career is trauma, regardless if it's fire, if it's paramedics, or if it's health nurses, if it's nurses, whatever. The career basically is dealing with trauma, because it's traumatic events that you're dealing with. So that you're not going to be able to avoid. Unfortunately, I'm really, the frustration with it is a lack of action. If there would be some positive action, I'll be honest, I really struggle with the way harm reduction is rolled out in Vancouver. I'm not comfortable with it, because every time something seems to go wrong, the rhetoric is the war on drugs, the war on drugs. And to be honest with you, some of the terminology that's being used, I don't think it's necessarily consulting people within the policing profession. I cringe when I hear the phrase a contaminated drug supply. Down specifically where I work, the drug of choice is fentanyl. People are not seeking out heroin, they are seeking out fentanyl because of the unique high they get from it. We have people, I just arrested somebody a little while ago, didn't charge them, but the drugs that were seized from them, I actually had it analyzed, the multiple samples, and he said he was selling heroin. And he told me that he has trouble selling the heroin, whereas if he has fentanyl, it will move a lot faster than the heroin will. That sort of blew me away. The other part is that when people are overdosing, they tell us that other people are saying they actually want to find out what that person bought, because they want to, that's what they want, that's what they're seeking out, because they realize that it's not bunk, it's not fake dope, that it's potentially fentanyl, and that's what they want, and they will go seeking that particular batch out. When I say batch, fentanyl for us, a lot of it's being colored, being dyed with colors. So we have purple, the green, the reds, and everything. And when people overdose on, like I'd say, purple fent, people will go out seeking it because they believe it to be a potent or a good high. So it's a lot of the terminology. So contaminated drug supply, that one I really struggle with, and this is specifically to the downtown east side, because it's not contaminated, because that's what people are seeking out. That is what they want to use. So dealing with the frustration for myself, for a lot of my coworkers, it's funny because Kim was saying that people that they've known for a long time, they're switching to opioids. We're starting to see people that are falling off. People, unfortunately, they're dying. People that I've known for the last 15 years. Quite a few of them in the last year have passed away. And I think for me, the bigger one is that nothing is being done for them, whether it be the severely mentally ill who should be, unfortunately, like I don't want to say institutionalized, but they should be provided a safe place to live on 60 acres of rolling meadows where they can chase squirrels all day. And I'm not saying that to be mean, but just they are productive people, and like they certainly have motivations and they have energy to do things. But the way they're surviving, I find it so cruel, and that's what I get frustrated with. Seeing some action, because like I said, I've been down here since 2006. And they keep talking about the mental health component, and all I keep hearing is that it's a tragedy. It's a tragedy. You know what? Well, yeah, it's been a tragedy for probably 20 to 30 years, and nobody has done something about it. Do something. You know, everything else. I can deal with the other parts of it. I made this career choice. I am not complaining about what I've done for a career. I've seen horrible things, but I've also believe I've done some good things, some positive things, and I'll trade those off with each other. But the frustration is the lack of movement from government. And the other one I keep hearing is decriminalization, right? Or legalization. I'm extremely frustrated at that, mostly from the perspective of the potential harm it could have for youth. So, sorry. Thank you for letting me vent again. I'll sit here now and turn my mic off.
All right, thank you so much, David. Superintendent Dara, if you want to go ahead and answer that second question. I paused you before, and I'm excited to hear your answer.
Okay, well, I don't know what can I say after David's comments there. Anyways, from my perspective and from the perspective of the people I work with, we're not so much impacted by attending overdoses and being able to administer the naloxone there, because when we do save somebody and we bring them back to life, it's a good feeling for the first responders, and they feel that they've been able to make a difference in somebody's life. When they attend an overdose fatality, well, we attend so many fatalities and so many, like David said, so many more gruesome scenes that an overdose fatality is usually more subdued or less graphic and less traumatizing. And but like David said, where we do have frustrations, and where the frustrations lie is that when we deal with the same people and we bring them to the hospital to get checked out, to get cared for, they just seem to get released without any follow-up. And this is where I think that society, especially the way we treat mental health, and like Pierre said earlier, I don't know that we treat mental health like an illness because there is no follow-up. If I had a heart attack and I brought to the emergency, I'm going to have proper follow-up. But with mental illness, there is no proper follow-up. And we have to look as a society, what have we done well and not well in the last 30, 40 years in treating mental health illnesses? I don't know that as a society we've actually advanced in this field. And that's where the frustration lies for first responders. We keep dealing with the same people with mental illness. We bring them to the hospital, they get released. Sometimes within the hour of dropping them off at the hospital. And you know what? We do this a number of times, and then finally we attend a call where this person that we know fully well has finally passed away of an overdose. And you know what? We can't help but feel sorry for that person and seeing that, you know what, at the end of the day, the system let this person down. So as a society, we really need to do a better job at providing better care for people with mental illnesses, which is related to the opioid crisis. And what else do I want to say? Yeah, so that's essentially our frustrations in this opioid crisis, is that nothing is actually being done to really help these people.
Okay, thank you for sharing that with us. Kim, I'm going to go ahead to you for your thoughts on that question.
Yeah, I have to say I agree with both the panelists before me. I agree with David as far as housing and having a nice place for people to be. David, we have one of our physicians is a farmer, and we joke with him all the time about these clients that he needs to take out to his farm and keep out there with him. We're always talking about all these farm hands he could have, but in seriousness, housing is a huge issue for us, and I completely agree. Like, the shelter is not a home, and it's not a place where people are going to get well. You know, when you look at, we have a room in our shelter where there's literally 100 men sleeping together. If you didn't have a mental health issue before you went there, you sure do after that, because I'm sorry, sleeping with 100 men, snoring, talking with themselves, reliving their trauma, like, so yeah, and I agree. I think, again, when you talk about mental health issues, I'm a mental health nurse, and I think when I think about what breaks my heart all the time is the people that I know and I've cared about who should be getting way better treatment than they are. And it's somebody who, you know, like, does silly things like brings people mints so they keep taking their antipsychotics, you know, the little things that you have to do to try and keep people on their medication. And then, but you know, the system, I feel like as a nurse that's been in the shelter, you know, we get kind of this pressure to fix everything about a person. We take care of their mental health, we take care of their medical health, we take care of their addiction, but we are in a shelter, and it's not an optimal place for people's health or wellness at all. And so I do, yeah, I feel like these people are forgotten about, you know, and that they are very much outsiders in our community. And so, yeah, I think that's my frustration. I really struggled with the question too when I first read it, of like, what do you do? This as somebody, I definitely help support our staff with their own mental health struggles. And at times I've had mental health struggles of my own doing this work. I think the big thing I really believe in and I carry with me is about the importance of creating, you know, a sense within the teams that you're working with of togetherness and unity and like trying to do this together. And I do find, you know, I've been supposed to be working myself out of a job from the beginning. We're not supposed to have homelessness. And unfortunately, we just keep growing. Like there just becomes more need. And so I think, yeah, so my big thing is as we keep growing and becoming an organization, that sense of like a family and sticking together and, you know, but we lose staff because of the work we do. Like and I agree with David, it is inherently traumatic work that we do. And so I think if there's people that cannot do it for the long haul, and on some level, I laugh. I'm like, I don't think any of us should be doing this for the long haul, but it's how you support your family. It's and you love it. Like I love my work. I love, you know, my favorite clients are old people with schizophrenia talking to themselves that smell like pee. Like I love what I do, but it also breaks my heart. So I think it is a struggle, but I think what I always rely on is, you know, seeing the other people with me doing that work. And sometimes it means crying together. Sometimes it means hugging each other. Sometimes it means laughing at really morbid humor. Like David said, I completely agree. I was going to join you on your bottle of rum, but yeah, I mean, you find ways of your own resilience. We have our resilience in still doing what we're doing, and you have to work as a team to keep your resilience. I think that would be my big thing of how you keep doing this, and try not to actually turn to the alcohol, because that you know, we'll try, but we joke about it a lot.
Perfect. Well, thank you so much for that. I do want to just offer Pierre, I think you're still with us, a couple of minutes just to kind of share the leadership perspective with us and the paramedic perspective on the crisis and what you've been doing. And then I'm going to give the last question to Dr. Carlton. So Pierre, if you are still there and want to answer for a few minutes, you can go ahead.
Yeah, thanks for that, Emily. Yeah, just a couple of items. When we talk about the evolution of the paramedic experience with the individuals in terms of the clients that we serve in our community, you know, over the last number of years, there's been a real sense of an evolution of recognizing the sense of humility, and that, you know, oftentimes we have the greatest ability to empathize when we can place ourselves in that situation. And I think more and more you're seeing that first responders, and I'll speak with paramedics, have that capacity, which is really kind of an important piece with respect to the education and in terms of the service we provide to our communities. I think the note that I want to bring forward is that, and it goes back to a little bit what David was talking about, when you have cumulative exposure, where you see the same individual over and over, that there is, you know, and I'm no expert in the mental health area, I'll leave that back to Nicholas. Dr. Carlton, is with respect to compassion fatigue, and this concept of, you know, the cumulative trauma, and the fact that as much as we've gained this ability to have a greater humility and share the experience in terms of where somebody is with respect to the empathy, what is a counterbalance, is almost a counterweight, is the difficulty that it presents in terms of the cumulative trauma and compassion fatigue. And just to speak really briefly about what the go forward is which relates back to my first part of my presentation, was that recognizing that mental health is an important aspect and a responsibility for leaderships within the paramedic community. And you know, just speaking briefly, here in Ottawa, we have a significant peer support group that really is available to paramedics to express and to really and it's not so much dealing with, it's understanding and appreciating the events that they take place in their day-to-day work. So you know, I'm a big advocate for the concept of peer support, non-judgmental, and it really is an important piece to maintain the health and safety of paramedics in their day-to-day work. I'll turn it back to Dr. Carlton. Thank you, Emily.
Thank you, Pierre.
Access code or meeting.
that. Dr. Carlton, is there anything that you'd like to say, just final words?
I think Pierre did a terrific job. We're really seeing a confluence of factors impacting our public safety personnel during COVID and the opioid epidemic. And the narratives today, I think, really underscore the challenges our PSP are facing with respect to cumulative trauma, compassion fatigue, and moral injuries. I think mental health is absolutely critical to be engaged with on a regular basis. I think peer support, as Pierre mentioned, is a huge, and as I heard others mention, is a huge part of our solution. But I think we're going to need a multifaceted solution that will be ongoing in order to meet the challenges of this multifaceted set of problems right now. So I look forward to us hopefully seeing advances in these areas and seeing real improvements for the front line as people have requested today. Thank you, Emily.
Perfect. All right. Well, I want to take the opportunity again to thank our presenters and our panelists today for sharing their experience with us. I think it's very valuable for us to hear what's going on with the front line and what their concerns and frustrations are. As we reach the end of our session, I want to ask everybody to complete the survey that will appear at the end of the session. You'll receive a follow-up email tomorrow with a video of today's session. We also hope you'll join us for our next webinar on December the 17th, where we'll be continuing the post-traumatic stress injuries series, talking to about three more innovative projects. If you haven't signed up already, the link will be available on our website, and it will be in the follow-up email as well. Again, thank you everyone for being here today and taking time.
Good morning, It's Rich Phelan here. As mentioned,